This animation illustrates the detailed steps of a total hip replacement using the direct anterior approach. This technique is increasingly utilized for its potential benefits, including reduced muscle damage and faster recovery. Patient preparation begins with standard surgical draping to create a sterile field. Crucially, an Ioban drape, characterized by its orange color and adhesive properties, is applied directly to the skin over the surgical site. This iodine-impregnated drape further enhances sterility. The surgical approach commences with an oblique skin incision. Note the trajectory. Starting medial and superior, the incision line extends distally and laterally, positioned within the tensor fasciae lata region after penetrating the skin layers. This specific incision angle is a hallmark of the anterior approach. Following the skin incision, dissection proceeds through the subcutaneous tissues. We now visualize the tensor fasciae lata, or TFL. As we progress into the deeper dissection layers, it is vital to identify and carefully protect the lateral femoral cutaneous nerve, or LFCN. During this deeper dissection, the lateral femoral cutaneous nerve is typically encountered medially within the surgical field. Surgical technique ensures gentle retraction and avoidance of direct pressure or injury to this nerve to minimize the risk of postoperative nerve-related symptoms. Next, we address the tensor fascia lata fascia, or TFL fascia. The fascia overlying the tensor fascia lata muscle is carefully incised. This incision exposes the underlying interval between the tensor fascia lata and sartorius muscles. With the rectus femoris fascia released, the rectus femoris muscle itself is gently retracted medially. This crucial step provides exposure to the underlying anterior hip capsule, the ligamentous structure surrounding the hip joint. By retracting the rectus medially, we gain access to the interior aspect of the acetabulum and hip joint. Before proceeding with hip dislocation, meticulous preparation of the acetabulum is performed. Any labrum, the cartilaginous rim of the acetabulum, and any osteophytes or bone spurs along the acetabular rim are carefully removed. This ensures optimal seating of the acetabular component and minimizes potential impingement. To facilitate hip dislocation, traction is applied to the femur. We demonstrate a subtle distraction force, creating a small amount of space within the hip joint. A Murphy skid, a specialized surgical retractor, is then inserted into the hip joint from the medial side. This instrument will aid in controlled and atraumatic hip dislocation. Traction is now released. With the Murphy skid in position, the leg is externally rotated. The Murphy skid acts as a lever, gently assisting in the controlled dislocation of the hip. The femoral head is carefully separated from the acetabulum, utilizing external rotation and the medial levering action of the Murphy skid. Throughout the initial dislocation, a critical step in acetabular exposure is the release of the hip capsule. The hip capsule is carefully incised or released. This release is essential to allow the femur to be maneuvered more freely and to provide unobstructed access to the acetabulum for component implantation. By releasing the capsule, we gain the necessary mobility to work effectively within the hip socket. Process, it is important to note that the rectus femoris muscle remains initially intact. This muscle is preserved in the anterior approach at this stage, contributing to reduced muscle disruption. With the hip dislocated, we now focus on preparing the femoral head for resurfacing. The femur is positioned in extension and external rotation to optimize surgical access. Retractors are strategically placed to maintain exposure and protect surrounding tissues. A retractor is positioned behind the greater trochanter to safeguard the gluteus medius muscle. Additional retractors are placed to ensure optimal visualization of the femoral head. Femoral head preparation for resurfacing is a precise procedure. A thin layer of articular cartilage and underlying bone is carefully removed from the femoral head. The goal is to create a precisely shaped surface to receive the femoral resurfacing cap. Crucially, the overall shape and size of the femoral head are preserved, unlike in total hip replacement. This bone-conserving aspect is a key feature of hip resurfacing. The prepared femoral head is now ready to receive the femoral resurfacing cap component. This cap is carefully implanted and secured onto the prepared femoral head surface. The cap is designed to precisely fit the shaped femoral head, restoring a smooth articulating surface. For optimal ergonomics during femoral head preparation, the surgical table is lowered to approximately mid-waist height. This adjustment facilitates surgical access and comfort during this phase of the procedure. Acetabular preparation now commences with reaming. Microport reamers, or similar specialized reamers, are utilized to precisely shape and prepare the acetabular bone bed. Reaming creates an optimal surface for secure acetabular cup implantation. The acetabular cup component is then carefully placed into the prepared acetabulum. Initial placement is often performed by hand. To ensure complete seating and proper orientation, an acetabular cup tamp, or impactor, is used. The tamp is used to gently impact the cup into position, achieving secure fixation within the acetabulum. For optimal ergonomics during acetabular preparation and cup implantation, the surgical table is raised to approximately shoulder height. This elevation provides improved surgical access and visualization within the acetabular cavity. With both the femoral resurfacing cap and acetabular cup successfully implanted, the hip resurfacing procedure using the direct anterior approach is nearing completion.